All right. Well, good afternoon, everyone. Thank you for joining us this Friday afternoon, at least Friday afternoon if you're on the East Coast. Thank you for joining us. It's Friday, so at NMQF, I say the word edutain. We like to educate and edutain you about some good topics in the health and healthcare space, typically around the health equity. But before we start this webinar and I turn it over to Courtney, I wanted to say thank you to all the veterans as we enter Veterans Day, the Veterans Day weekend and this holiday on Tuesday, and say thank you for all your work, not only you, but your families and all that support you. So appreciate you all. But it's also Friday again, and I want to make sure that you know that what we're doing, and the best person that's going to lead us to today's conversation is our very own Courtney Lang. Courtney Lang has been with NMQF, I don't want to say since the beginning, but I would say her and Gretchen have probably the best stories about the starting and continuance of the organization. She is she's a lawyer by training, and in addition to her work in the health care space. She teaches law, and I believe she's getting her master's in divinity right now as well. So she's gonna keep us sane and prayed for and all of that. And I'm gonna turn it over as she leads the discussion on data equity.
Thank you, Brandon, for that very generous and spiritual introduction. I appreciate it. And good morning, everyone. Welcome to the Data Equity Coalition webinar on interoperability, the engine that drives data equity, why SPD 15 matters. Our coalition around data equity is designed to advance equitable data standards so that race, ethnicity, language, gender, identity, sexual orientation, and disability and geography are collected, shared, and used to improve health policy and care. We have been on this journey since September of 2022, and our coalition is co-convened by the National Minority Equality Forum and Blue Cross Blue Shield Association. I'm going to briefly introduce our panels, but wanted to remind the audience that at any time, please add your questions via the Q&A function, and we're going to reserve time at the end to answer your questions. So use the Q&A function to answer and ask questions, and then the chat feature is just for general comments. So before we begin, briefly, Aishat Magbade is the Director of Health Equity Policy at Blue Cross Blue Shield Association, with a background in public health policy, advocacy, and health equity. She began her role at BCBSA in 2022, and she works on a variety of issues. Her background hails from both life sciences and government relations, as well as federal policy at ASCO and the American Society of Microbiology. She will be joined by Chinyonye Onwunli, who is the Managing Director of Health Information Technology Policy at BCBSA. She's also a lecturer of health administration at NYU's Robert F. Wagner Graduate School of Public Service. Prior to BCBSA, she was the Senior Policy Analyst and Branch Chief at the Office of National Coordinator for Health Information Technology, now the Assistant Secretary for Technology Policy, ASTP, within the Department of Health and Human Services. She is an expert in health IT regulation and policy. I want to take this moment and say thank you to our speakers, our members, our friends of the Data Equity Coalition. We are delighted that you are with us today. And so without further ado, let's get started with Gretchen Wortman bringing us welcome on behalf of the National Minority Equality Forum. And Gretchen is the Vice President of the Institute for Equity in Health Policy and Practice. Gretchen, the floor is yours.
Well, thank you, Courtney, and good afternoon. On behalf of Dr. Gary Puckrin, I welcome you to this webinar on the topic of interoperability, which is the critical component, indeed the engine, of systems change towards equity for all population cohorts. We have a very ambitious agenda today, so I'll save any further remarks for later. Again, I welcome you to this essential conversation, and I return the podium to Ms. Lang.
Thank you, Gretchen, for that warm welcome. And our first speaker for today will be Aishat, who's going to actually help us to understand what, in fact, do we mean by data equity? What does it mean, Aishat, and why is SPD 15 so important? Aishat, the floor is yours.
Thank you, Courtney, and thank you, Gretchen, for that lovely welcome. Hello, everyone. It's nice to be with you all today. So, what is data equity? At its core, data equity is about fairness in data practice. It ensures that data collection, analysis, and use does not favor one group over the other and allows that populations that may be invisible in the data are actually visible when data is collected. Um, it aims to empower all communities, especially those that have been historically marginalized or overlooked. So, data equity involves several key principles such as inclusivity, transparency, accountability, and accessibility. Um, so, Courtney mentioned the Data Equity Coalition, which I am proud to represent BCBSA on. Standardizing data for health equity is very important, and data standards and just data in general is foundational in order for us to achieve health equity. Our mission is to develop and recommend policy solutions that advocate for data standards across race, ethnicity, language, sexual orientation, gender identity, as well as disability, geography, social drivers of health, and just creating a full intersectional view of our health, our data, and ourselves, and ensuring that all of us are seen within the data sets that are collected by different stakeholders across the country. So, in order to achieve health equity, we work to advance policy, engage with different political leaders and lawmakers on both the state and federal level, as well as educating the community and key stakeholders. This is really important because SPD 15 is not something that everyone knows. SPD 15 is not household language, but the core of SPD 15 is. We interact with SPD 15 constantly. Whenever you're asked about your race and ethnicity, that is SPD 15. Those questions about your race and ethnicity came actually from the 1997 revision of SPD 15. The fact that you see those categories listed there also came from SPD 15. We all have this um, engagement with SPD 15, and it's really a part of our everyday lives. So, what is SPD 15? If we could go to the next slide. Thank you. So, SPD 15 was created by the Office of Management and Budget, and it's called Statistical Policy Directive number 15, which is what SPD 15 stands for. And it was created in 1977 in cooperation with other federal agencies to provide consistent data on race and ethnicity throughout the federal government, including through the decennial census, through different household surveys, and other federal administrative forms. So the goals of SPD 15 are to ensure that there's comparability of race and ethnicity data collection across all federal data sets, and to maximize the quality of these data sets by ensuring that the format, language, and procedures for collecting this data is consistent. So, in order to do this, SPD 15 provides the minimum set of categories that all federal agencies must use when collecting race and ethnicity data collection, regardless of what sort of collection mechanism that they use. So in March of last year, OMB decided to revise SPD 15. And within this revision included an expanded list of the minimum categories for race and ethnicity, including removing the MENA category from white and making it its own separate minimum reporting category. So this allows that the people that are part of the Middle Eastern and North African community are able to be seen more clearly within data sets that are collected by different stakeholders. It also combined the race and ethnicity questions into one question and allowed for people to actually check off their ethnicity underneath their race or write in their ethnicity even if they don't see their race. This allows for more granular data collection, which will allow that for these communities to be seen within the data sets. So as you keep hearing, being visible within the data sets are really important to ensure that we can track and measure disparities and also measure how programs and initiatives that we are developing help to close those disparity gaps that we see. So In SPD 15, the federal agency action plans were supposed to be completed and submitted to OMB in September of this year. However, in September, OMB decided to extend the deadline for implementation. So the action plans are now going to be due in March of next year, and full implementation has now been pushed to September of 2029. So this presents an opportunity for us to continue our advocacy for SPD 15, to continue to work with federal agencies on how to form their action plans to ensure that everyone is seen within the data, and to ensure that the data practices of the federal government remain equitable under SPD 15. And a major component of that is interoperability. Interoperability is very core to the data sharing and SPD 15. So with that, I'm going to turn it over to my colleague Chinyone Onwuli to talk about SPD 15 and interoperability and how they're connected.
Thank you. Thank you very much, Aishat. Good night. Good afternoon, everyone. I'm happy to be here. Well, now that we've talked about SPD 15 and the federal commitment to more accurate and inclusive demographic data, I want to zoom out and connect that to the broader question of how equity shows up in our health data systems. Now, before we dive into data equity, I want to start out by laying out what we actually mean when we say interoperability. Next slide, please. Now, in simple terms, interoperability means that health information can move seamlessly and securely between people and systems that need it, whether that's a doctor, a health plan, a hospital, or a public health agency. It's what allows your lab results, medication lists, or care plan to follow you and not get stuck in one electronic health record system, one office, or one organization's portal. When interoperability works, ideally every care team member, that's your doctor, your care manager, your insurer, they're all working from the same playbook. That means that it's turning from a fragmented care operation to coordinated care. Because when data moves freely, we get better care coordination, we get fewer medical errors, faster prior authorizations, and more personalized treatment. It also means that there is less time on paperwork, fewer repeated tests, and ideally, no more clipboards in the waiting room. Now, at the systems level, interoperability helps us measure quality, understand population health, and address disparities. And when we connect that data to insights about race, ethnicity, language, or social needs, we start to see the full picture of what's driving health outcomes. And that is the bridge to data equity. The federal government plays a huge role. The Office of the National Coordinator for Health Information Technology, or ONC, has been leading the charge in interoperability policy. And ONC, which is now Assistant Secretary for Technology Policy, or ASTP, is responsible for establishing standards for health information technology systems for interoperability, privacy, and security. The organization supports research projects and initiatives that are aimed at advancing health IT and improving health IT adoption. And I'll talk a lot about this agency in the further slides. I will also mention APIs. An API is short for Application Programming Interface. An API is basically a digital bridge that lets two different computer systems talk to each other automatically and securely. Rather than needing to print or fax or re-enter information, APIs let software systems exchange that data in the background. Next slide, please. So when we talk about data equity, we're really talking about visibility. We're talking about who is represented in the data and who isn't. The key to that visibility is interoperability, which again is the ability for different systems to exchange, interpret, and use data consistently. Now, right now, our healthcare system generates massive amounts of data. from electronic health records to public health systems to payer data. But if those systems can't communicate, we can't see the full picture of health across populations. And that's why interoperability isn't just a technical issue, it's an equity issue. Now, ONC ASTP has a health IT certification program. And this program is the mechanism that ensures that all of this works in practice. It requires certified health IT systems and APIs to be able to collect and exchange standardized demographic and clinical data. So when we talk about the promise of SPD 15 and its improved race, ethnicity, and SOGI categories, interoperability is what makes those standards actionable. So now, without interoperability, data remains siloed and equity gaps remain invisible. Now, with it, we can connect information across payers, across providers, and public health agencies, giving us that population-level visibility that's necessary for our equity work.
Thank you, Chinyonye. I really appreciate the last comment, especially that data remains siloed if we don't lean in to make sure that data is made visible. And it really ties nicely with Aishat's initial comments on data equity really being the foundation for the health equity movement. I wanted just to briefly ask in your presentation about the link between data equity in really advancing equitable data standards, because I want to make sure that our audience understands that every single day we are interfacing with those demographic categories and even clinical categories for data. And so making sure that we're seen, that we're represented, also affirms us as patients, as individuals within the system of care. So question, how does interoperability link to data equity in terms of advancing those standards, those minimum standards that Aishat reviewed in the beginning?
Oh, certainly. Well, I get to speak to that in my next slide. Next slide, please. So we'll go ahead and connect the dots between SPD 15, USCDI, and the ONC Health IT Certification Program, because essentially they all work together for data equity. As we discussed earlier, the SPD 15 sets the federal standard for how we classify and collect data on race, ethnicity, and SOGI data. It gives us a shared vocabulary to have consistency for demographic data across programs. Now, the USCDI, or the U.S. Core Data for Interoperability, defines what data elements must be included and exchangeable in certified health IT systems. It includes data elements related to demographics, vital signs, medications, and social determinants of health. Now, ONC ASTP updates this core data set regularly through new versions like USCDI version 3 and USCDI version 4, which expand the data set to include more equity relevant elements, such as social determinants of health, disability status, and sexual orientation and gender identity. USCDI Plus allows agencies like CDC and CMS to extend those elements even further for specialized use cases. For example, public health reporting or quality measurement. So as SPD 15 evolves, ONC and ASTP can reflect those updated demographic classifications in future USCDI versions, making sure that there is technical and policy alignment across the ecosystem. Then we have the ONC Health IT Certification Program, which ensures that the health IT systems and electronic health records and APIs can actually implement those standards in practice using FHIR APIs for structured interoperable data exchange. Now, for those who are unfamiliar, Fast Healthcare Interoperability Resources, or FHIR, is a standard adopted by ONC ASTP. Now, essentially, it's a shared format for health data so that every system speaks the same digital language when sending and receiving information. The ONC certification program is what turns a federal standard into a requirement. It ensures that if a health IT product is certified, it must support the latest version of USCDI. And ONC presents the opportunity for public comment on the USCDI versions as they improve upon that data set. Also, the ONC certification program has updated its certification criteria for patient demographics and observations to align with the new race and ethnicity standards, and this will be found in the USCDI version 7. So together, these frameworks form a continuous improvement loop. SPD 15 defines categories and identity specifications. The USCDI integrates them into an interoperable data set. An ONC Health IT certification program ensures that every certified system can capture and exchange those fields. And as a plus, USCDI Plus allows agencies to go even further for specific policy and program needs. So you can see equity can evolve as our standards evolve.
Fantastic. Chinyonye, I just wanted to make sure, I was just going to jump in, that we wanted to really make sure that people understood how intersectional data is collected and how populations are not overlooked in health policy. And I know that you've spoken to the Data Equity Coalition about the importance of trust in that process. And how can we be assured that the process has integrity and that it's trustworthy?
Of course, interoperability and data equity cannot exist without trust. I think we can go to the next slide, please. So the more detailed and personal the data we collect like race, ethnicity, sexual orientation, and gender identity, the more we must earn and maintain the public's trust. And so this is where privacy and governance comes in. ONC's certified systems must already meet strict privacy and security requirements. That's doing things like encryption, access control, and audit logging. But this all goes deeper than just security compliance. HIPAA protects identifiable health data that is held by covered entities. That's providers, health plans, clearinghouses, and their business associates. Health data may be used for treatment, payment, or healthcare operations, but not for unrelated purposes without authorization. So when data moves outside of HIPAA, for example, to community programs or social services, state privacy laws and data use agreements fill that gap. So promoting appropriate data sharing and promoting consent and transparency ultimately strengthens trust and encourages accurate self-identification. And people need to know who can access their information, how it will be used, and what protections are in place. That's how we encourage more accurate self-identification and richer participation in equity data collection. Aligning SPD 15 and the USCDI implementation with frameworks like HIPAA, cyber incidents reporting, and state privacy laws will be critical to protect privacy overall. And when communities can trust how their data is being used, they're more likely to share it. And when data is complete and reliable, equity analysis becomes more accurate and it becomes more powerful. So to wrap up, data equity requires both standards and data stewardship. We can't close gaps that we can't see, and we can't see gaps without interoperable, standardized, and trustworthy data. So SPD 15 defines who we count, and USCDI defines how we share that information, and the ONC Health IT certification program ensures that that technology behind it actually works securely, consistently, and equitably. So I'll stress that this is a continuous process. SPD 15 may be revised in the future, and USCDI will continue to expand through new versions and through new USCDI plus datasets. Therefore, interoperability becomes a mechanism that keeps equity moving forward. So now with standards, interoperability, and trust, we don't just improve data collection, we improve outcomes, representation, and accountability across our health system. So it's all how we make sure today that we don't leave everyone or anyone else behind tomorrow. Thank you.
Oh, thank you, Chinyonye. We appreciate your thoughtful TED Talk, our little mini TED Talk that we've just listened to. And thank you so much for having the Data Equity Coalition logo visible on the screen. I think now we're going to just kind of go into gallery mode. I do have a few questions for our panelists and a follow-up question specifically for Chinyonye, and I appreciate how you concluded. We can't close gaps that we cannot see. We can't close gaps that we cannot see, sort of that unmasking of what is meant by data equity and interoperability as the engine. Is there a way, we have a number of advocates on the line, we have a number of advocacy organizations, 25 plus with the Data Equity Coalition and another 10 to 15 friends of the Data Equity Coalition organizationally. And the number one question is, how can advocates get involved? It's a lot of information to sort of digest and process, but is there a way for them to participate and weigh in on the information that you've just shared around interoperability?
Sure, that's a really important question, because equity isn't just about collecting data. It's about making sure that data represents everyone. And as far as how advocates can get involved, I always say comment period is power. Every time OMB, CMS, or ASTP opens a rule for framework or opens a rule or a framework for public input, community organizations can and should weigh in. Coalitions like the Data Equity Coalition, civil rights groups, local health equity networks can push agencies to require more granular data collection and to report it transparently. So I would say that intersectional data equity doesn't happen by accident, but it happens when we design our systems to see people more fully, and when advocates keep those systems honest by participating in comment periods of power.
Absolutely. And we love that. We try to share that information broadly and encourage all of those who are watching us and participating today and online to weigh in on public comment opportunities. Definitely, Data Equity Coalition will help to continue to socialize when those opportunities are made available and to flag those as an important toolkit as a part of your advocacy. iShot, what are the risks associated with data when data is not disaggregated? It's collected and not acted upon. How is that harmful?
Thanks, Courtney. So collecting data is the first step in identifying the problem. With more granular data collection standards, it makes it easier for us to see who is being impacted and how that data can inform policymaking, the development of different programs and other initiatives to address the problem. If the data is collected but not acted upon, it can lead to these problems not being addressed in a timely manner, which means that the issues that these communities face can be impacted negatively, and their problems can actually be exacerbated, and disparity gaps can widen because of this. An example of this is like through care coordination and case management. This is something that health insurance companies, providers, hospital systems, primary care all work together to ensure that the patient has adequate case management and care coordination. But if we collect this data and don't act upon it, it makes that very difficult. It makes it difficult to coordinate and deliver more holistic, patient-centered care and facilitate connections to additional interventions and resources that people may need. So without acting upon the data just sits there and the problems never get addressed.
You talked about that. Thank you. You talked about that in your opening comments around why data equity is so important. And you reviewed for us the minimum categories that SPD 15's update last March articulated, that we advocated for, these minimum standards. But can you share with the audience why those are just the minimum and why we should continue to ask for the maximum, like pushing beyond the minimum? Why is that so important for representation, being seen, ensuring that populations, communities, individuals can see themselves within this ecosystem of healthcare?
That's a great question. So, for example, with the inclusion of the Middle Eastern and North African category, it allows that community to really be seen in the data. There are so many different communities that exist within this country, and these minimum categories may be able to get closer to understanding how different things impact these various populations and communities, but there's always an opportunity to go further. And that's what I really like about this 2024 revision is the ability to actually write in your ethnicity and not just be confined to whatever checkboxes are included when you see the question. So this allows for people to identify as who they see themselves and really show themselves within the data. So this is really important for us to continue to advocate. The more we learn, the more we talk to different communities about how they are being seen in the data, to work with the federal government to expand these categories so that everyone in the country is well represented within data sets from the federal government, and that trickles down through every aspect of our lives, state level, local level, and in the private sector as well.
I think that's such an important point that you made, that every single day we are interfacing with the impact and the outcomes of data equity. And so I don't know that we necessarily identify it as such, but we're participating even without identifying that this is actually data equity every single time we're interfacing. And so, Chinyonye, you had brought up about interoperability within federal data sets, but I wanted to know if you could just reinforce accountability. How do we hold accountability for interoperability within federal data sets? If we're just the average person, we're advocates, we are out here doing the work, just trying to make sure that equity and equitable data is not sunset or lost in today's environment.
Yes, certainly. Now, when we're talking about enforcing accountability, it's really about how we as stakeholders make sure that the government follows through on its interoperability and data equity commitments. With the standards like SPD 15, the government has really given us a foundation. But accountability does depend on implementation, and that's where we as stakeholders matter. Stakeholders can keep agencies accountable by tracking whether or not they've published their action plans, updated their data collections to meet SPD 15. Again, public comment periods, Hill briefings, coalition letters, et cetera, they all make sure that standards don't necessarily just sit on paper. Stakeholders can build SPD 15 aligned data collection in their own systems. When private sector and states are already using some of the same categories and they're using the same FHIR-based APIs, it assists upon the federal government to stay interoperable and to stay consistent. Federal data standards only drive equity if they're implemented, and that happens when stakeholders demand transparency, when we as stakeholders also model compliance ourselves, and show how consistent data improves outcomes.
I appreciate that, because you said the important if clause. If they are implemented, and this is the energy that the Data Equity Coalition is consistently trying to elevate and accelerate. So we are committed to implementation of those minimum standards. Gretchen, feel free to jump in at any time as well. I wanted to just briefly follow up, Chinyonye. You said a couple of acronyms, but just in case someone joined late, they might not have heard what those acronyms are. So you talked about APIs and you talked about FHIR. So I wanted to know if you could just reiterate for the audience the definition of those. And in your earlier remarks, you talked about APIs in terms of the relationship between different sectors within data collection. So the opportunity to communicate between hospitals and health systems and pharmacy and physician offices. I just wanted us to dial back because I don't want anyone left behind in this conversation, because I do believe this is fundamental to our work as health equity champions. If you could just reiterate.
I'm sorry.
Okay. I'm sorry, Gretchen. I wanted her to just give the acronym definitions. Okay. APIs and FHIR, and then Gretchen was going to jump in after you.
No problem. So I did mention APIs quite a bit, which was short or is short for application programming interfaces.
Right.
And APIs is essentially a digital bridge that lets two different computer systems talk to each other automatically and securely. And so, as I mentioned earlier, rather than having to re-enter information or print or fax and send that information, APIs let software systems exchange that data in the background. And they do have specific APIs for different sectors. CMS has requirements around certain APIs right now, where there's payer-to-payer, provider APIs, and patient access APIs. Won't necessarily get into that now, but there is that same bridge for different sectors and different applications, but basically to make sure that the software systems can exchange that data in the background. We also talked about FHIR, and FHIR is a data standard that ONC ASTP adopted, and it is essentially a shared format for health data, so that every system speaks that same digital language when sending and receiving information. And they use that data standard to develop those APIs. Now, FHIR is FHIR, and it stands for Fast Healthcare Interoperability Resources.
Exactly. Thank you. Gretchen, you have the floor. Thank you, Chinyonye, for just clarifying that for the audience.
No, thank you. And these have been extraordinary presentations by Chinyonye and Aisha. And I want to thank all of the organizations who have joined the Data Equity Coalition and encourage you to help us identify other organizations who should join the coalition for the following reason, one of the following reasons. What I've been hearing a lot of is how essentially AI is going to enable us to create an infrastructure that can improve equity and quality. AI, that term hasn't been used, but I'm tending to think of everything because of the way the systems interact. I think a question for all of us going forward, and by all of us, I mean those who are listening to this call as well, which is not explicitly linked to the mission of the Data Equity Coalition, is how this capacity we're building for interoperability is going to change the behavior of the research delivery and financing system. How we monitor and evaluate and fine-tune the data elements that are collected, the standardization of those data elements, and monitor changes in outcomes of healthcare for all population cohorts. I think it's important that we not assume that there are those who are already receiving the best that our system can provide, because our knowledge will always grow. And making sure that those data equity standards and the interoperability of the systems that make that information available are informing the care, the research, the policy that affects every population cohort. So it's, and that's what I meant by AI, and thank you for giving me the floor. How do we then link this to diagnosis and treatment guidelines? And how do we link the outcome of diagnosis and treatment guidelines to improving the data that we collect and making sure that all of those systems are communicating in a way that is proactive for the humans in whom the change must be measured. So
Gretchen appreciates that, especially the emphasis around care coordination, because fundamentally what we're trying to do is to ensure that seamless communication, the data bridge that Shinyonye so beautifully articulated, to make sure that that digital bridge, the data bridging of information sets, is done in such a way that all of the systems and touch points within care are able to seamlessly and equitably communicate who we are, where we are, and how we show up in healthcare. And so with that, Aishat, just wanted to turn over to you about what policy recommendations would you perhaps prioritize we take a look at beyond the federal level, but maybe taking a look at to the state level, just to see, are there things that we can be looking out for, monitoring, just socializing our awareness too, so that our advocacy network can be better informed?
Thanks, Courtney. And that's a great question. So I mentioned earlier that part of data equity not only includes working with the federal government, but also working with state governments, local governments, and within the private sector. A policy recommendation that I would prioritize would be aligning state data collection efforts for race and ethnicity with the 2024 revision of SPD 15. Federal and state alignment is really important when it comes to data standards, and that would improve interoperability and also allow for better data sharing across different entities. I would also prioritize states collaborating with national standard setting bodies to develop data standards for other types of data, not just race and ethnicity, but sexual orientation and gender identity, social drivers of health needs data, and disability data. If states continue to adopt standards developed by a national third party that can be implemented across the country, then it will also improve interoperability and data sharing as well. It's important for stakeholders to track and measure and analyze the data that's being collected and work together to find solutions to address all the issues that are seen through the data that impact specific communities. So I would recommend those two, just really having states align with current standards and also adopting other standards that different organizations are developing.
Okay, friends, align and adopt. Align with the minimum standards and adaptation. Really key pivot points, because the number one question that we get asked, besides what can I do, and Shinyonye gave you the sort of the key here, public comment opportunities, and now Aishat is telling specifically what you can do, leaning in on the state level, alignment and adaptation, bringing us to this point in our webinar program. We want you to utilize the Q&A function within the feature on your platform to submit any questions that you have for our panelists. In addition to that, we did have some questions that were sent in advance. And so I am going to open up this section for Q&A broadly to our audience. So again, feel free to submit those right now. Number one question that came in just now is, why does this conversation around data and interoperability matter to patient and provider advocates? Why does it matter? I feel like we have socialized this throughout the context of this conversation, but maybe we just want to kind of reinforce a pearl here. So Aisha, floor is yours there. Why does it matter to patient and provider advocates?
Courtney. So this matters to both patients and provider advocates because improving health outcomes and ensuring that patients receive equitable, quality healthcare are important points for both the patient and the provider. Data equity is foundational to achieving this equitable, quality healthcare. So when the data allows everyone to be visible, there's more clarity on how communities are impacted. So without this data, it's hard to identify who is impacted, and it becomes increasingly challenging to measure the impact of any interventions that different stakeholders create to address these issues within this community. More granular data collection categories means that people are seen and therefore heard. So that's why it matters to us. We all talk about how the healthcare system needs to work better for us, needs to serve us, but it cannot pinpoint where there are gaps, whether it be gaps in outcomes, gaps in access, without having the data. So this is why it's really important for patients and advocates to think about SPD 15 and just data standards more broadly.
Thank you. Beautifully stated. One of the areas, Chinyonye, that you highlighted spoke specifically to outcomes, representation, and accountability. So question, I'm synthesizing one of the questions that came in through the chat. How can harmonizing data standards and transparency in data collection close some of those long-standing gaps in access, outcome, accountability? And specifically, there was a participant who wanted us to kind of clarify what we meant by siloed versus visibility as it related to data.
So I'll take the second question. So
Okay.
first,
Okay.
what we meant by siloed as it relates to data visibility. When we collect information, oftentimes the information can be in one space, one sector, one electronic health system, and it doesn't necessarily move to the next sector, next system. So you have community health data in one space, you have provider information in another space, you have healthcare, payer data and claims data in another space. And what we want to do is be able to sort of make sure that information flows in different sectors or within different systems, even if within the same sector. And that helps show the whole health, if you will, of the whole person. So that helps with visibility, not just of one individual, but at the population level, you get to see the whole picture of a whole section, whether it's race or ethnicity or sexual identity, sexual orientation or identity. We want to break down silos for better visibility and representation. Can you restate the first question for me, please?
Yeah, so the person asked, how does harmonizing data standards and transparency in data collection help to support closing gaps around access, outcomes, and accountability?
Definitely harmonizing data standards, as long as those data standards are translatable one-to-one from different collection specifications. It's easier for that information to be readable and translatable. And where there's more consistency, it ends up closing the gap, right? So you're able to translate that information in a way that is digestible and usable and actionable. And that's the means in which we close the data equity gap.
Thank you for reiterating that. And just so that our audience is clear, if we're collecting data at the state level, say we're in California and we're collecting data a particular way, but at the federal level, we have a different standard, then what it does, it really upsets the opportunity for us to be consistent in our data collection. And the consistency and having congruent data allows full representation. And what Aisha and Chinyonye and Gretchen and I have been talking about is really making sure that there is visibility so that each individual in the system of care, that coordinated care that Gretchen spoke about, is seen, represented, it's the identity. So we don't want incongruent data collection sets. Our ideal is that those minimum standards are maintained, but that we continue to push for more so that your identity is always represented within the data movement. So we want to make sure that that's the case. We did have a question that came in specifically about how individuals within organizations can see themselves in terms of engaging in activities or case studies to showcase the importance of data equity. They were interested in socializing data equity activities at their annual conference. And so, Aishat, I thought maybe you could kind of just share with them some of the information that we've been communicating more broadly within the coalition.
Thanks, Courtney. First, I would love to offer the Data Equity Coalition to come attend your conference. We love to be in these spaces to talk about data equity, talk about the work of the coalition, and work with other stakeholders towards our common goal of achieving health equity. There are different ways that you can help to socialize health equity or data equity and SPD 15. So, talking about how it shows up in our daily lives, where we see SPD 15, and also the impact of actually having that self-reported data. What is that data used for? What can it inform? So, for example, for providers, data can help, demographic data for race and ethnicity can help healthcare systems build a workforce that is representative of the communities that they serve. They can only get this information by understanding what race and ethnicities, what communities they or populations live in their communities to ensure that they have a representative workforce, which then leads to more culturally appropriate care from the provider and the patient, which then fosters trust. There's also an opportunity for people to really think about how they can provide that culturally competent care. So, for example, if I'm Nigerian and I know that how some Nigerians would like to be talked to or helped when it comes to their healthcare may be different from another ethnicity or another nationality. I'm just thinking about how you can work with your community in order to address data equity. So, just really talking about why it's important, how it shows up in our lives, and how you within your healthcare organization can continue to advance data equity and share with your patients or your members why it's important in their lives.
Thank you, Aisha. Yes, we welcome your participation. Absolutely. Anytime that we can be of service to the community at large, the Data Equity Coalition is here for you. One question about disability data. Aisha, I'm going to follow up with you, and then others feel free to chime in. What are some best practices for defining disability-related data to promote equity in healthcare? And so, Aisha, this kind of touches on some of our past work around intersectionality, how we don't just show up as one siloed box, which Chinyonye was talking about. We're not in a silo, right? So while respecting individuals who may choose not to disclose or not to make visible or invisible their disabilities, right? So what are some best practice of defining disability-related data to promote equity?
It's a great question, Courtney. So there are standards when it comes to collecting disability data. Same way when you apply for a job and you see the race and ethnicity questions, you also see the disability questions. There's an opportunity for us to expand those categories and really drill down into the different types of disabilities that exist. Some are able to be seen, some are not able to be seen. Some are physical, some are more neurological. So those are the types of things that we need to think about when coming up with a definition for disability data. NCQA, which provides a number of different accreditations for different stakeholders within the healthcare system, such as health plans, is now requiring the collection of disability data starting next summer in order to get their health equity accreditation. So it goes back to the point that Courtney was making about intersectionality. NCQA is also mandating race and ethnicity, disaggregation across different quality measures and things of this nature. So once you start to look at someone through an intersectional lens and seeing how the different parts of their identities impact their health outcomes, whether it be their access to care, their relationship with their providers, their health outcomes, their clinical health outcomes, their social needs, all of these things intertwine with each other. So the Data Equity Coalition is also going to be working with our members to see like how can we standardize disability data collection categories? How can we make sure that all people who have disabilities are able to feel comfortable disclosing their disabilities, especially within the healthcare setting, so that they can get the care that they need? So that's definitely something to consider more broadly.
Yes, thank you for that. And we do have some resources that are available on the Data Equity Coalition website specifically. And also in the chat, there's a comment that had been made about helpful to alert patients and their families around trusted supportive services before any type of crisis intervenes around some of the disability discussion that we just had. So definitely encourage we'll put the QR code up at the end as well, but to go to the website. As we near the end of the hour in our time together, I just wanted to briefly touch on, we overviewed interoperability and how it serves as the engine for data equity. We discussed enabling how data moves seamlessly across systems to support more inclusive representation of populations to inform healthcare insights. And we reference real-world practical application of how data really intersects with public policy, technology, and practice, so that harmonizing, we had a question about harmonizing, how harmonizing standards and transparency in data collection helps to motivate and ensure that we have long-standing closure of gaps in care so that individuals have access, they have outcomes, they have accountability. We encourage you to pursue public comments. We talked about alignment and adaptation and the necessity of making sure that that digital bridge that Chinyonye so appropriately educated us about with the APIs allows us to have outcomes, representation, and accountability, because we cannot close gaps that we cannot see. And our goal from the Data Equity Coalition is that you are seen within each healthcare touch point in this ecosystem that we find ourselves in. Panelists, I am going to ask you to give a final thought for the audience in 30 seconds or less. Aishat, I'm going to begin with you and then go to Chinyonye and then Gretchen.
Thanks, Courtney. My final thought is education. Educating people about SPD 15 and data equity in general allows people to really be tapped into how these different components and policies impact their daily lives. Because they see SPD 15 throughout their lives, but may not necessarily understand how it actually impacts them and what this data is being used for. I think as stakeholders, as we're collecting this data, it's really important for us to share with the people that we're collecting the data from why it's being collected and foster trust and transparency between the healthcare system and the people that we serve.
Thank you. Education, Chinyonye.
My final thought would be building on that education, data literacy. One thing that we can do today is to make interoperability and SPD 15 understandable in plain language. So I know it sounds really technical, but at the end of the day, it's about people understanding how their own data and how your own data, helps shape equity. So we should talk about interoperability and data standards, not just as tech or federal mandates, but as tools that makes every community's data, whether that's race, ethnicity, identity, a visible tool for decision-making. Workshops and webinars like this one, especially that describe how APIs work and facilitate data moving safely between clinics, payers, and researchers, but also letting them know that they will have access to data themselves.
Thank you. Gretchen, 30 seconds.
Well, thank you. I I think what's important for me to communicate is that in addition to, or as an expansion of the work that we're doing that's focused on SPD 15, OMB, and how the federal government implements these guidelines, is to ask our audience to look at this issue through the lens of the work they do within their organizations, and how knowledge of this system of information can inform research and innovation to assure that all population cohorts in this country have an experience that's enhanced by the availability of these data.
Thank you so much. Education, data literacy, looking within to see how innovation and within your organizations helps to fuel this broader narrative. A final thank you to our esteemed panel, as well as to the National Minority Quality Forum and Blue Cross Blue Shield Association. The Data Equity Coalition is visible right now on your screen. We encourage you to go to our website. And with that, we thank you for being tremendous healthcare advocates. Dr. Gary Puckrin, we want to thank you for this platform and have an enjoyable day.
Thank you, Courtney. Thank you all.